You can go to
Yes.
if she's got questions on something. Sure. It'll be. All right, at this time, I'd like to call the April 15th, 2026 Board of Health meeting to order. First item, if we could call roll for me, Jenny.
Sure. Here?
Here.
Here.
Here. Here.
Thank you. We have a quorum. So next item on the agenda is the adoption of the agenda. So hopefully everybody's had a chance to review it.
Mr. President, can I just insert really quick about
So
the change in the agenda? I'm so sorry. Under item number 2631, if we could strike the environmental unit and the food services and pool unit fee schedules, we will not be discussing those today. Only the nursing unit.
thank you.
Thank you.
Any other comments or questions, or if not, I'll entertain a motion.
I move to approve the agenda as revised.
Second.
We have a motion and a second. Any further discussion? Hearing none, all those in favor, please say aye.
Aye.
Opposed, say nay. Motion carries. Next item on the agenda is the approval of the minutes from our March 25th, 2026 board meeting. Hopefully everybody's had a chance to review them. Entertain any questions or comments or a motion regarding the minutes.
I move to approve the minutes.
Second.
Motion and a second. Any further discussion? Hearing none, all those in favor, please say aye.
Aye.
Opposed, say nay. Motion carries. Board President announcements. I don't have any announcements today. Please go out and vote. Next item on the agenda, health officers presentation and report. Dr. Migliori.
Thank you. Before we get started with business, I would like to take this opportunity to acknowledge one of our retiring long-term staff members. It's a very bittersweet time for us this week. Her last day officially is on Friday, and we're going to be having a lunch on Friday in the department. But this is the last time that she'll be with you in her official capacity as the director of the foods unit. Mike, I think, has something he would like to say. And I would like to say that Miss Carolyn has been with the department for just a shy couple months, under 30 years. And if you think about that, how many people do you know have been in a job for 30 years and have done such an extraordinary, impeccable job? And so I really can't say how bittersweet this is for us. We're so happy that she's starting the next chapter of her life, but we're very sad to be losing her from our staff.
Thank you. Carolyn. Friday, April 17th will mark Carolyn Smith's last day with the Department of Health. We recognize not just a retirement, but an extraordinary career of service. For over 29 years, Ms. Carolyn has been a steady and trusted presence in our department and in this community. Through her leadership in food and pool services, she has quietly but profoundly protected the health of countless residents. Every inspection completed, every standard upheld has helped prevent illness and has kept families in St. Joseph County safe. Much of this work goes unseen and perhaps is not fully appreciated by most people in the county. But for those of us who recognize the hard work, dedication, and the care that Carolyn provides, we understand how invaluable that impact truly is. More than her work, we recognize who she is. Known to so many as Miss Carolyn, that title says it all. It reflects the respect, warmth, and kindness she brings to every interaction. She's been a mentor, a leader, and to many, a friend. We also know how much her faith, her family, and especially her grandson means to her. As she begins this next chapter, we hope it's filled with time spent with the people she loves, moments of joy, and maybe even a little more of her favorite color, which is purple. Miss Carolyn, we thank you for the impact and legacy you leave behind on us and our community. You will be deeply missed and warmly remembered. Thank you for taking care of all of us.
Oh.
Thank you for those comments, Mike. Thank you, Carolyn. On behalf of the board, thank you for your years of service. You've always been just a rock and just a solid leader in the group. And I appreciate seem to have everything under control all the time. And if you don't, you hide it very well. So, and I think the community senses that as well, that you're just a solid leader for us. You will be missed. Anybody, any board or even the public, if you've got any comments or like to share I have.
I know when I first met you, when I came around to meet all the different departments, I was so impressed with you and how much you could tell just from that first meeting, how much you cared about what you were doing. So you will definitely be missed, but thank you for all your hard work. 30 years is very impressive.
I'm just thankful that you put up with me when I started editing and the food code for grammar and punctuation. So thank you so much. It was always very comforting to know that the food service department was always in good hands. I'm sure it still will be, but you'll be missed.
Is it true you're leaving because Mike Harding's back on the board?
Be careful, they'll have you come back in a different form.
All right. Well, thank you, Carolyn. If you have any comments you'd like to make, I know you're pretty, quiet generally. If you'd like to. I don't mind at all. Absolutely.
I shared in the managers meeting something that I read recently. It's an old saying or adage. If you want to go fast, go alone. If you want to go far, go together. And 30 years is a long time. I have been here longer than some of the staff is old, but it has been an honor to serve in the position and an honor to serve with, so many people who also care, the board, administration, staff, the other units. And we are truly a team and a family. So it has been bittersweet, waking up at 2 and 3 in the morning, thinking about it. My daughter says, I don't understand, Mike, but no, she doesn't understand. So again, I just want to say thank you all for allowing me to do the job that it's been a privilege to do for the last 30 years, almost. Thank you.
Thank you, Carolyn. I just want to highlight a few things from the board packet. In the care unit, I wanted you to take note on page 9 of the graph of the new chronic health screening, chronic disease program that we've just started. It just started in March. And I know this is a quarterly report, January through March, but this health screening just started in the month of March. It's a kind of a slower rollout because we've got to figure out where the people are, where we want to be. And shout out to the care team, to their leadership, to Renata and Alyssa. They have done an impeccable job in getting the staff trained, getting them comfortable, and making sure they have the tools for their tool belt to carry out this important work. But I wanted to tell you that, they screened 51 people, and of the 51, they found that it was 27.5% have high blood pressure, 34% have either prediabetes or diabetes, 45% had elevated BMIs, and only about 1% had elevated cholesterols. This is new information to most of the people. A woman was found to be diabetic and she had no idea that she was diabetic. And having the community health workers run these events, they're able to get people hooked up with providers, give them education, provide them with education about what this means and what they can do in the short term to help, but also in the long term to help. So for me, these numbers just for the first month were the percentages are a little scary. Where our target audience are the uninsured or the underinsured. or people who just don't go to the doctor for, or don't have a provider, this was an opportunity to do sort of a quick health checkup. The other thing that I wanted to point out to you involves the maternal infant health program. And this is on page 12, these statistics. For the month of March, this is at the Women's Care Center, they saw 59 clients. And for me, I found it interesting when you look at the age of the 59 that they saw, their average age, 51% of the group was 25 to 35 years of age. And then the ethnicity, over 49% were Hispanic, and about the equal number of Black or African American and whites in the clients that they did see. About 68% were uninsured, and about 47.5% did not have a primary care doctor, so about half. Interestingly, even though around 63% this was not their first pregnancy, about 47.5% didn't have an OBGYN that they were hooked up with, or a midwife. The other thing that I found interesting with this data, and again, it's preliminary, it's early, in the year, but about 46% of the people that were served of the 59 were found in 2 zip codes. So we are looking at this and taking it to heart and seeing where we need to direct some of our future programming and innovative ways we can apply for grants to address needs in riskier areas, how we can address potentially preconception health. We're looking at grants to do that. And then having this information, this data helps us to try and direct to the areas of highest need. So I found that very interesting. The other thing that I wanted to point out to you is when you look at some of the things in here, like, for example, bites, or, how many events we did, remember that this is over not 30 days, but rather pretty much 20 days. And so when you see that we have, 60 bites a month, that's more than 2 bites a day. And so when you look at the numbers, try and remember that this is over a 5-day week, 4 days, 4 weeks and a month, so 20 days. Do you have any question? And then also the nursing unit, to point out to you that we had 130 animal bites during the month of March. That's a lot. Now, anybody that goes to the ER, those get, reported down to us or urgent care, but that's a lot of bites. I'm sorry, not for the month of March, but for the quarter. That's a lot of bites. But I also wanted to point out the different immunization clinics that we're serving is to help kids get caught up on their vaccines. So like in high school, there's certain vaccines you need before your senior year. Meningitis is one of them. And this is to help students who need those vaccines to keep up to date with their school requirements. So we are serving, again, Dukem Center. That's we do a rotation there at least once a month, and they have people coming and going, but like tetanus shots during the appropriate season, if people want flu shots, we give them flu shots. But a lot of this is trying to help members of our community that may not have access to get to the county building for immunizations. Do you have any particular questions about this health report before we start our unit spotlight? There's a lot of information here, and it's good data to have for when we're doing program direction. The unit directors and assistant directors have just been incredible about working hard. They're really working hard. They're trying to figure out how to help people. They're trying to figure out where the greatest need is. And we're offering our services across a wide swath of the community. We're in the libraries for doing our chronic health disease screenings right now. And we're just trying to figure out where we can do the most good.
So for the maternal health initiatives, you mentioned these are clients that you see through being at the Women's Care Center. But it sounds like based on the zip codes, more of them are coming out because they have center downtown, they've got one in Mishawaka, and they've got one on the northwest side of the airport. So it sounds like it's that area that's serving the northwest side where it's more of a there's the most access to care issues when it
Correct.
comes to getting hooked up with an OB and okay. So do you just even in terms of how you're staffing the different centers with the CHWs, because I know they kind of float around, right?
Correct.
Are they at that location? Are they getting more clients at that location where they need to come in and assist and kind of do their part to help with insurance? Or do they tend to be that location more, or are they still kind of?
I don't know.
evenly distributed?
Renata, can you speak to that? Do you know if there is more traffic in the
Sure.
northwest location?
Or just maybe how do you kind of decide, because it's two CHWs, how do you decide in general where they go?
Renata Williams, Director of Care Unit. It is one CHW since we had our cuts.
Oh.
But
okay.
we rotate depending on Women's Care Center and what location is the busiest. So the 46628, that's what we refer to as the west location, I believe. And we do have an additional rotation at that
Okay.
location, that in Notre Dame, I believe, and then one at Mishawaka. So of the 5 days of the week, 4 days, she's at one of those locations. Mhm.
And since you're up here, I guess, for the chronic health disease, right now you said you're mostly going to the libraries. So
Yeah.
which libraries have you visited and what's kind of next on your radar, your next stops?
So the libraries are what we consider our primary partnership, and we have, and again, this was based off of the library's recommendation and their busiest times. So we coordinated with them just because we don't know. This first quarter, we're taking back that data to see if that matches up from what they thought would be the busiest times. So really, is that the busiest times for us, and we will adjust. But we have several locations, Western, Maine, a few more I can't think of, right? We have been in New Carlisle too. We're looking for opportunity in Lakeville and Walkerton, which I know that's not St. Joe County Public Library. So we have several location rotations. Some are more than other. For example, the New Carlisle, we're there once a month. Some of the locations for like Main Street, we're there maybe twice a week or twice every other week or whatever. So it just depends. And then we have some secondary locations like One Roof, United Way's One Roof location. We also are at the Upper Room and Dukem Center and the Kroc Center. And so we're just like slowly building up based on capacity. So we add a new location, taking time to see like what that volume is going to be like before we add others. Yeah.
Do the midwives still work from Beacon at the women's care centers?
That I do not know.
I don't think so. I think the midwives at Beacon have been helping out at the HealthLink clinic. No, yeah.
Last I knew they were at the places where you are. So that's why I wondered, we had like what you said, 46% don't have a provider. It seems like we need to partner with them and with the residency programs to maybe, because just from my own study in this field, most of the demographic that don't have a provider don't trust providers. So if they can get in there and talk to them, maybe have them come in and do a highlight during one of your classes so they can see, well, this person's pretty nice, or that they listen, or so that way they don't feel intimidated to get a provider, because a lot of times they have stuff going on. They don't trust that they're not gonna turn them in or, do things, this, but it's like, I feel like we could grab some of the residency programs and the midwives and say, can you come in and just talk and tell us about what you do? And that way there's a personal connection. it might help them to feel more safe to
We do
actually
have the residencies. As you know, there's been a pretty big turnover in terms of obstetricians and other OBGYN healthcare providers in this community. And we really haven't backfilled a lot of those positions. So we have talked to both residency programs, but they're really at capacity in terms of like, many people don't take Medicaid. And so that's the insurance du jour for many of the obstetrical patients they're seeing. And both residency clinics are at capacity for their OB care. They just don't have any room left. So we did talk to them about that. It's tough out
Where do we
there.
guide them then? Where are we guiding them?
So we have several locations that our MIH coordinator is often in contact with to see who's taking new patients. So we do have E. Blair, Warner, St. Joe, the Health Link, and all of those. So sometimes it depends on insurance, and sometimes it depends on the patient or the client too. Sometimes they may have had an experience where they don't want to go to one location or another. So it's kind of individualized. We have not come into a situation where somebody needed prenatal care or to find an OBGYN and one was not available. So
Transportation is also an issue for like Indiana Health Center also does some of those, some of that care, but it's hard.
Yeah, and are we doing anything with our nursing program coordination to initiate even some prenatal visits? Because that can be very basic. We're already doing vitals on people. We can always draw their labs. Like, are we doing any of that?
We don't have any capacity, any bandwidth to do any clinical care right now.
Okay.
I see there's a huge need in the community and I think it will get larger.
Because early start prenatal care, it makes the hugest difference in
Absolutely.
outcomes. So that's why I'm like, if the midwives at Beacon are doing the Indiana Health Center and we're funneling people, I wish there was some way we could make a connection where they feel safe and that they are heard, but we're starting something for them. Even the labs and a blood pressure and like what you guys do for the health screening for adults, even that is so invaluable to just check maybe as part of our prenatal education.
yeah, and I think that's why the CHWs develop that relationship and also do that follow-up. So a lot of the reports that you probably see is new patients, but we also carry an old patient caseload. And so part of the workflow is to also follow up with the women from the intake. Did you go to the doctor? What did they say? Were there any concerns? Were there any barriers? If transportation or childcare was an issue, so they can help address some of those things early on. That's the whole point of meeting women at Women's Care Center, because that's early in pregnancy, so that we can make sure they're early to care. Yeah.
We just don't incorporate any checking their vitals or anything, right? Or
No. No.
We're working on getting that. It's a work in progress and that's something we are working on. It's just a matter of how much bandwidth we have because we also have home visits after delivery that we're 100. We have 100 women right now that are getting home visits on a regular basis. And we're trying to teach moms, encouraging them to breastfeed. We've got a couple people that are getting certified in lactation. We're really trying to hit the hottest fires first. And then they're all important, but
I'm just thinking the first contact, and if we could even just do their blood pressure.
and I know the Women's Care Center, they're very, very pro getting somebody in that first trimester somewhere to get their labs, get their blood, get established. But we're working on building out a program. It's a matter of whether we get the grant or not to do it, but you're right on our tail.
No, I need to talk to some people.
You need to chase us more.
No, I'm willing to, no.
We can use you as a resource. Well, I mean, that's awesome. And the Ember program, we're still beefing that up too and carrying it out, farther as a support for those moms and what the work that Renata and Alyssa are doing with their team, it really is incredible.
Big gap filler. But you said before, reach out. If we put some on even the midwife program at Memorial, they have 9 midwives there now. So if we can pressure Memorial.
Do they take Medicaid? Okay,
Charge of them, they have to. So that kind of thing.
All right, thank you.
that's good to know.
Mhm.
Thank you,
Thank you,
Renata.
Anything else on the health officer's report?
No,
Questions for Dr. McLaury before we go to the spotlight? All right. Time for our spotlight.
Hello.
Hello.
We're going to talk about finances today. And next slide. I just wanted to briefly go over, we are in our annual budget season. We did begin discussions with administration and the unit directors to discuss the allotment of funds for each unit. We are now going through and having those funds, or having those meetings with those units and administration. Those will start later this week and into next week, where we will discuss the budgets proposed by each of the units. We do have a few budgets that would be going through the process this year. And the reason for doing all of these at budget time is so they hit the ground running January 1st. Otherwise, I can't start the budget process until January, and it would be approved then by March if I wait to see what a fund balance is. So I always try to do a best guesstimate for the items related to the opioid restricted fund, the school liaison, the trust fund, and the NACHO mentor program. Chances are I'll probably have to do some type of amendment during 2027 to take funds away that aren't available, because I will overestimate just to make sure all the funds are captured. And then in early May, we do have a meeting already prepared to meet with the Finance Committee to review all of the draft budgets. Once that does receive a favorable recommendation from the Finance Committee, it will go to the full Board of Health, which will be at the May 20th meeting, pending any changes in that schedule. I did find out from Abby Doyle, who is the Deputy Auditor, they are not coming out with guidance until May 12th. That is, it does not fit into my timeline. June 1st is the deadline for the HFI funding to state. So I do have to keep those meetings currently in place. If I'm able to squeeze in the county health fund budget as well, I will try to do so I don't have to create additional meetings. So just a heads up, we may have to schedule a separate Finance Committee meeting and then a separate Board of Health meeting for a quorum to approve those budgets. I'm hoping nothing crazy comes out of their guidance that, we're trying to, I guess, look into the crystal ball for what they're going to request us to have. I do have a few different versions going, so we could pull the trigger at any time if we wanted to approve the different versions, and then whatever guidance comes out, we can decide that at the Finance Committee that we have, I believe, in early May. I have that June 1st. The information is due into the financial system. That will probably be a different date locally if we're only getting guidance by May 12th. I can't imagine they would assume us to turn it around that quick, but they might. And then late July, early August is when the doctors and myself will meet with the elected officials to go through and present all of the budgets and answer questions that they have. And then usually by middle of November, everything is approved locally, and then it goes downstate for the DLGF. So hot and heavy in the budget season. So more to come on that as we meet. Next
Amy-
slide. Oh,
Amy, is there any reason you'd want to move the Finance Committee meeting back up till May 12th or after? Or does that not help you?
we could, however, then I wouldn't have enough. I don't know if there would be enough time for changes and then the packet to be posted ahead of the May 20th meeting. I can look with Jenny to see what the timeline would be for that if we met maybe like on the 13th or 14th to see if that's something that could.
Fine either way, just whatever I think will work best for you.
Yeah, I'll work with Jenny to see what alternatives we have to present for that meeting. As we look at this chart here, this is the revenue stream for every funding source that we have had beginning with 2019 up into some information for 2026. The only exact revenue number that we have for 2026, of course, is HFI, since we did get that deposit at the beginning of January. But I did want to highlight each of those lines separately. First, beginning with the tax support, that has gradually increased. Going back to 2019, it actually has increased by 65% to what we had in 2025. The percentage or the tax rate goes up slightly, but then the amount of property tax that is collected has seemed to increase. Of course, we have to keep in mind the Senate Enrolled Act 1 is yet to have an impact on the tax support that we receive. So we are unclear on how that is going to impact us going further. Regarding the county health fees, which is the orange line, that has been somewhat steady, I would say. However, in mid 2024 is when we did have to eliminate charging for our property transfers, which was a significant source of revenue for environmental health and the Department of Health. And then going forward with the new food code that will be coming out regarding the mobile permits, where we are only able to charge $450, but $250 of that goes to the state, and we can keep we get to keep $200 of that. So not knowing how that's going to impact us, how many of the vendors will be getting their state license from our office. We also have some miscellaneous revenue that we never budget for, just because that could be a return check, a refund that comes to us. That's unexpected revenue. So I never make an estimation on what we would receive regarding miscellaneous revenue. HFI funding, of course, is the sharpest increase and then decrease, starting with, of course, $0 in 23 and our first deposit in 24, going up in 25, and then the 73% reduction that we continually talk about that has come down from 2025 having $6.3 million deposited to $1.7 million for 26 and 27, because they do approve those in 2-year cycles. So we know the next amount for 2027 will be at a minimum the $1.701 million. Now that amount can increase if we do have counties in the state of Indiana that opt out of HFI funding. They take the amount that that county would have gotten and then spread it out amongst the counties that have opted in. So just knowing we wouldn't get any less than 1.701 million for 2027. Other funding?
Can I ask a quick question?
Yeah.
I'm a little surprised at the funding levels back in 2019. Is there other funding there that's not part of the dollars for some reason? Just thinking back to, COVID time and.
The purple line, the other funding, or what are you?
Just the total of all the funding in 2019 just seems really low. I thought we were getting more grants from the state at that time, or.
No, not until 2020, late 2020 to 2021 is when we had the influx of grants from the State Department of Health specifically related to COVID. During that time, I was managing 20 grants. And now we're down to like 4. Prior to COVID, we did have maybe 6 or 7, but none of them were the large dollar amounts like we did receive during the COVID pandemic.
So from 2020 to 2026 in your grants, you're about the same as you were, you're saying. So, right? For grants.
Correct.
And are we still digging and digging and digging and trying to find grants, or are they just not out there?
No, absolutely. I'll touch on that. Absolutely. Yeah. going to the other funding, the purple, that is going to be the two funds that aren't considered grants. That was the countywide lead initiative as well as the MIH initiative. So those were funds that we had received, was not renewable. Once we received HFI, the county commissioners and county council stopped the countywide lead initiative. So that funding did not receive any new revenue for quite some time. And the MIH initiative was a presentation that was held at Century Center where sponsors paid for, or not necessarily sponsors, we charged for attendance. So those were considered the other funding sources. And then touching on grants, as you can see, the sharp increase, partly related to COVID, but then also in 2021 is when we received our multi-year CHW CDC grant. So that was, almost $1 million each year for that funding as well. And you add that on top of COVID, we had a significant spike in revenue. I do want to mention the decrease in 2025 for revenue it was impacted, of course, by the two clawbacks that we had, one being the immunization COAD grant. And with that one, it was just short of $200,000. And then the CHW CDC grant was just shy of $350,000 that was clawed back and no longer available for us to use. The last category is donations, and that is the one donation in 2024 from the Fair Foundation for the School Health Liaison Program. Next slide. Now, as we talk about expenditures, not as colorful as the other chart, county health, we have seen a steady increase. We have over the last few years, going back to 2022, we have put in and been approved for salary increases. So that's going to be the majority of the increase in expenditures is we had a higher salary for staff. Yeah. This is this is updated. Yep, this will go out after the meeting.
Okay.
Yes. Yes, I had to make some tweaks because I think I left off donations on the expenditure slide as well.
This is what we are, this is what's accurate.
Correct.
Okay.
Correct. As we talk about HFI funding, the peak that we have for HFI funding was, of course, we got programs off the ground. We had staff hired, 2025 even more so. And then 2025, we did have an increase in dollars for our community partnerships where we raised it from 2024 to 2025. So all that attributes to the rise in expenditures between 24 and 25. And then, of course, 2026 will definitely be a decline in expenditures just because we budgeted less than what we had for 2025. So even expecting, if we spent everything we had budgeted, it is going to be a decline from 25 to 26. The other funding, again, is the MIH initiative as well as the countywide lead initiative. Both of those, they were not receiving any new revenue for quite some time. But the MIH initiative was fully expended as of December 2024, and the countywide lead initiative as of June 2025. Once the funding ended for the countywide lead initiative and no other external funding sources were secured, that program did move to HFI funding. As we talk about grants, which is going to be the blue line on the chart there, pretty much similar to the revenue with grants. Some of our grants, the majority of our grants actually are reimbursement based. So I have to spend the money, submit the receipt, and get back exactly what I had spent. We did have a few deliverable based grants where funds were received once we completed deliverables, those being our school liaison grant and our NACCHO mentor grant. So that the revenue and expenditures for those two wouldn't line up if we were looking at them individually because funds were received in a lump sum and then we spent them. Also talking about the two clawbacks again. Obviously, we couldn't spend those funds because they weren't available for us to spend. Same thing being a reimbursable grant just wasn't available for us to use. And donations, that is, of course, for the Fair Foundation. The $50,000 was not fully expended between 24 and 25. We do still have some funds available that we reappropriated for this year. And we still have available through our school liaison program that she is working with the schools for any needs that they have. Next slide. So this is where this will be probably the most change from the slide that you had in your packet. As we plan for the future, of course, as we learned, I believe it was within 24 hours of learning of the two clawbacks from each other and the reduction in HFI funding. Administration met to prepare a 5-year plan, and that is currently in place and would make us solvent through 2031. Of course, if we were to receive any increase in tax support, fees, or HFI funding, or any external funding as well, that plan would extend us past 2031. We currently have only one active grant that is receiving new revenues, and that is held by the county commissioners. It is the opioid restricted fund that we are able to use for our injury prevention program. Otherwise, the other grants, the other 3 grants that we have are using fund balances to run the programs. They're not receiving any new funds. So once those funding sources end, we would have to look for other funds to secure it. If we are unsuccessful, those programs will also move to HFI if HFI funding is available for those programs. Next slide. We do continue to seek out and apply for external funding to further develop our programs. I know CARE has been very active in applying for grants. I'm helping them with budgets left and right. One of the hurdles that we found with these grant applications is they want new programs developed. They don't want to fund current programs. And with our current level of staffing, we're finding that difficult to add to our plate. So we're being mindful of the programs that we are able to add and what programs would benefit our staff and not put a load on our staff that we're not able to increase, our capacity that we have. It seems there are fewer grants available. It just doesn't seem like there are many out there available. And we obviously have a lot more competitive applications out there. Everyone's looking for grants now. So it is a very competitive market, but we do continue to keep our eyes open. Doctor's always sending anything she gets from the state. We try to internally, if we hear of anything. Our state, our Northern Region Finance Director, she is excellent at sending us funding opportunities that she has heard about. So we do have that resource with our Northern Region Finance Director where they are keeping us up to date on what is available. We do continue to network with those in our community to establish, create, and nurture relationships. We also have been identifying opportunities to bill for services provided by the department within our various units. Of course, outside of like the nursing unit, some of the home visits that our care unit does, or some of the MIH visits that they do, we are exploring the option of billing for those to have a stream of revenue that we haven't tapped into before. And then lastly, at last month's Board of Health meeting, we definitely want to engage our community and get them involved. We are close to the finalization of our foundation. And this will definitely provide an avenue for them to support the Department of Health and make a donation to further our reach and our programs within our county. Answer any questions?
Was that video by Jason Critchlow, was that aimed at this deficit problem?
I think, Doctor shared that with me. I feel like that was 100% related to the HFI presentation that we made last month. He took the time to look at our packet, look at our presentation, and definitely put out the information that we want to go out to the community, that the funding cuts by state is what's clearly going to hurt the most, going from 6.3 million down to 1.7 million for this year and next year, and not knowing what's going to happen the years after that.
So let's go to step two then. What do you think? As the department would be the appropriate next steps to engage the community in a variety of sources to help us restore that funding?
I just think it's getting the word out. I just don't think enough people know about our services and what we do. As we have the residents come to us and meet with each unit, they always say, I had no idea everything that the Department of Health does. I thought it was just shots, or I thought it was just to come get a birth certificate. We are just not known for everything that we actually offer within our department. And just having some type of, if maybe we could partner with someone for some free ad space, or, some radio, time or something like that, just to get the word out. I'm not sure how to do that. I don't watch TV myself. I don't listen to the radio. So I don't know, like for myself, like what would it be? Maybe social media, really push it out on all the social media, not just our social media, but ask other partners to, push out the information, or share whatever post we have to share it out to their pages.
Do we
Yeah.
have a marketer per se that?
We used to, but we had to eliminate that
Yeah, that was
position.
part of the budget cut.
Budget cuts. I can vouch for that with regards to the residency side of things. I've seen that personally, having lived it.
Mhm.
I won't say how long ago.
We still have the residents that rotate through Memorial.
Great to do that.
Yeah,
You don't- how is
And
HOA?
Memorial residents love doing it. They're so
I enjoyed it at
appreciative.
That other place. They don't do that anymore?
No, they don't. But I do have a St. Joe resident that has reached out to me. She would like to do like a 2-week rotation.
Yeah.
She's really interested.
Yeah.
And so I've said that's exactly what I said. Yeah, come on in. So the more relationships we build, we're going to the St. Joseph County Medical Society meeting in May and presenting, and a couple of the unit directors will be going with me. Thank God they're willing to take their evening off and go talk about what they do. But every opportunity we have to talk, we want to take advantage of. And we're always looking, I can always talk. Unfortunately for my husband.
It's easy access, this, you need this, go here, like, right? Someone's gone through that
Yes.
site and.
Yeah,
developed
we update it to make sure we try to keep it as updated as possible. So all the correct information is on the page as soon as you land on our page.
Amy, sorry. No, okay.
So as we've been doing this billing and coding venture, that you're right on with the, how do we take what we're doing and bill for it? So I don't know if we can be a credentialed Medicaid provider, under your
Yep,
name, like.
under my name, they can do
Yeah,
that.
so you can put a 25 modifier on any of the visits that anyone does, and you don't get a ton of money, but you get money for every visit. So
You have 100 home visits.
so we're doing that right already.
We're gearing up. Mike has been working with Jan Haley, and they are on the precipice of, everything always takes so much longer than I think it should, but it's just the nature of the business. And yeah, we're trying to get any extra money out of vaccines that VaxCare doesn't get. We're going to be doing home, lactation. We'll be able to charge for that consultation, follow up blood pressures in the home. Those are all, level 2.
Yeah.
So I'm with you. We're together.
And I know 3 people, providers of care, that have their own business that really, really understand this billing and coding nightmare. So I'm willing, I'll help you any way I can. So I don't know. There's
Yeah,
a lot of insight. that
There-
we have of like, ooh, you're missing this, you're missing this. you're missing this."
I've said that from day one. And so part of it was like getting everybody on Athena, getting rid of some of the software, consolidating, making us more efficient, getting people trained in efficiencies. And so it is, I'm an impatient person, but it is,
Like there's so much crazy stuff.
the wheels are turning, just, they've been greased.
Dr. Hayes.
Once the foundation is like 100% ready to rock and roll, what is the way to connect up and donate?
They would just reach out,
Is
the
it gonna be
board.
on the health
Di-
department website, or will there be a
Actually, does
link,
she
or
wanna
what's
talk
the?
about that? That's her baby.
Because I love that idea.
Yeah, Ashley Hellman, Director of Nursing. So yeah, we're really excited about the foundation getting started, and we will have multiple avenues for people to provide donations. We're going to be asking, we'll be doing individual asks in person to some of the people who have supported our programming in the past. We will have campaigns. They will hopefully be able to donate through our website because we will be connected to the department. Oh, no, they will not. They will not be able to donate through our website. Our foundation website, council, our foundation website.
Foundation?
The
Yes.
foundation
Our
website.
foundation website, yes.
I was gonna say, can you link
And-
it to the department?
It's a separate entity.
Yeah.
But
Right.
we're a tentacle, but you donate to the foundation and then the foundation donates it to.
Right. I'm just trying to figure out how to make sure people can easily get to it.
Yeah.
And if it's not connected, how do you get to it?
We can, so some of our departments are very good at creating flyers, social media, other things that are out there we push out, and they have community partners on them already. It's not just the Department of Health. So we can create those kinds of media that would allow people to click on QR codes or click on the links to
Okay.
donate that way. But as the county, we're not promoting any one non-for-profit over another non-for-profit. I mean, if you remember from the Health First funding, the grants, I mean, that was a big cycle of the board getting together and discussing all of the packages and all of the submissions and making sure everyone had a fair shot. So I understand, the goal of this one, but it is a separate entity and it supports the mission. But there's a lot of great community partners that support the Department of Health's mission.
There's
That's true.
a bazillion of them.
Okay.
Maybe we need a tag for that. Just our name is always at the top.
Any further questions
not
for
discriminate.
Amy on our finance spotlight?
Yes.
Yes, all right.
Can we get from you when the gloom and doom is going to hit unless we do something? What is the time frame for all of this to unfold where we realize HFI is going down to the low level?
Probably not until the next cycle downstate to know if they're going to fund HFI and at what level are they going to fund HFI.
Okay, so that would be step one, would be determine when is it going to impact our county the most? All right, so if we back up from there, if we're looking at designing with the end in mind, it would seem to me that we have enough time to have various conversations with members in the community to focus on the message that Mr. Critchlow is trying to project and do it in a systemic way where various agencies aren't duplicating or stepping on other people's toes to help us raise money for that period of time. So in the school business, we used to have, when we didn't know what to do, because we face this every 2 years, gloom and doom. In public schools, we'd have work sessions with the board to discuss openly what would be all the options and all of the resources that we all know or the contacts that we have. And so we have more time than an hour to talk about something so devastating. So my recommendation is that we take this one item along with the expertise and we come back together as a group and talk about the issues and lay out all the different things that we all know or contacts that we have, and then develop a comprehensive plan to go after various entities in the community or foundations or benefactors or donors. And so I can tell you that worked well in the school system because we never got any more money. It was always a deficit. So if we're going to bail out, we're going to have to figure out how to do it ourselves. And we can't do it in an hour meeting and once a month. And that's going to take a comprehensive plan. So if we have 2 years to generate some excitement and more collaborations and more community support, more PSA announcements like Mr. Critchlow, and more public awareness of the deficit. Because the problem is you don't know what you don't know. And if people in the community don't know that we're having this big problem, then that's our fault. That's our fault. So we need to make people aware. And there are a variety of agencies and broadcast journalism and all kinds of things that can help us sell the point. So I don't want to be sitting here 2 years from now saying the same thing after the state did it again. We should be better prepared, for a comprehensive plan. So that's just my recommendation that we.
I think it's good to remember that before HFI, we had the money. It was just in a lot of different grants from the state. So it's not like HFI was new funding. It was just repackaged. It was bundled. And the state aid has historically, the grants, the 20-some grants that you were managing basically got bundled together to become HFI. So it's not new money. That's the thing that I think is frustrating to me, that people was like, well, you got all this money. And it's like, well, really, it just got recycled into this. And it's much easier for Amy to manage one fund or 4 funds instead of, 20 different grants, because they all have different sets of rules, when they expire, what you can use it for. And so it's just much easier, but it's not new money. It's old money that has been there, and it was cut at the 11th hour. No one saw this coming. And getting 560, last spring was February, March, and April. It was like the spring massacre, because February we got one huge grant, clawed back the exact same day. We never saw it coming. And then within 4 weeks, a second huge grant, the CDC grant, clawed back the exact same day. We thought we were going to have to let people go at the end of that day. But thank goodness we were able to get together and fix it so that we didn't have to lay anybody off. But that was, $560,000 that was clawed back within a matter of 4 weeks. The following month, $4.7 million was taken out of our budget. We were good for the year, but they're like, at the end of this year, you're not going to be getting that.
Well, there's another factor here of the political arena in the city of South Bend and the impact that this will have on residents within the South Bend area. And then if you look at the county, and the county council appoints some of us and the mayor appoints some of us, and we all need to be concerned about this. It's not just a health board issue. And so at some point, there needs to be inclusion in the discussions to support what we have and build upon what we have, as opposed to constantly look, for outside resources that may or may not ever happen. Can't rely on the state to do much. So if it comes, it's gonna come from within our community here.
And I do still get calls from community partners saying, hey, can you help us out? And it's just after last year, we can't, we need to help ourselves out to stay sustainable.
That's an interesting point, though, how you presented HFI as being rebundled, because there is, and it would be, I'm not suggesting that anybody necessarily do this right now, 'cause it's perhaps extra work, but it would be interesting to see, like, going back, what are pre-HFI, what were through grants and other things, what were areas where the state was more involved in the funding process. And I know some of these grants, I suspect some of them were probably going to apply. They might have been county specific. Not everybody got them. HFI was more of like a blanket. Everybody gets this amount of money that can go toward XYZ and 13 other things. But it is a good reminder to think back historically, like, we even have those numbers, like historically about what amount of our budget was typically state funded or through the state grants. Just having that data, could be helpful in saying, going forward, hey, this is actually, it's kind of like education, a certain amount of education state funded, a certain amount of other things are state funded, and this is kind of actually historically been the case.
And we see the state
health.
struggling too. I mean, they're having us do the mobile food inspections, charging $450, and they want $250. I feel like Mamma Mia. I mean,
Update on that when we get to the fees.
it's just, we're doing the work and we are keeping not all of it.
Maybe it would be a good idea to to work on this piece of educating the community, to highlight what our programs are and what they mean to this community, and put those out on social media even, and just air the dirty laundry a little bit and just say, we don't have funding for this anymore. We're looking for partners. We're looking for support, and just start, because sometimes people don't know what we don't tell them. So it's like we assume that they know, or they don't care or whatever, but they just don't realize. They're like, what do you mean we can't get funding for that? What? And then people that do care will be able to respond, and we can put that right out on. We just have to be more open with the problems that we do have.
It's taken for granted. They don't know because it's taken for granted, not because they know and take it for granted, but because it just happens.
Right. And now we don't have it anymore, and we really want to, but we have 2 years or whatever and need help. Because I think people would respond, they just don't know. Because we know this community has a lot of money flying around, so that I think if you appeal to the hearts of people and make it personal for them, these people.
There's a subsidiarity aspect to what you're saying to the foundation, Jen, which is asking within the community.
And if people will
Support
come,
for those who are
if there was anyone that was willing to speak in a video about how a program we had helped them in a fundamental way, then that's the tug on the heartstring thing, where. What?
Were you here last night? Oh, we had a video.
Oh, you did?
Yeah.
Oh.
Did actually, it was
Yeah.
quite good.
I think this setting up the foundation is one of the avenues. that
Agreed.
We hope is going to help. What everybody is talking about.
It gives people the ability
Place
to
to go,
donate and
donate.
have
Yeah.
tax deduction.
So, now that that's close anyhow.
Or
Nope.
even help, volunteer, whatever.
We can talk about other ways to promote that or promote our issues that need support.
I think the bottom line, what you're talking about is just bringing back the funding for the community to the funding and taking responsibility for the community as part of the community and not having to worry about somebody else coming in and giving people more ownership of for their neighbor and all of that. So.
Okay. And I think Amy and Dr. McGlery have looked out many, many years on and say, what's the word? Different scenarios, figured out how long, we can go until there's a crisis. And I think we're assuming no drastic cuts were good for a few years or.
No, we're not anticipating any major changes. We're trying to batten down the hatches and roll up our sleeves.
I know you did that last year, so you were talking about the length of time
Right.
and it's.
Yeah. And
Explain
like in the
that.
presentation, like we're good through 2031, as long as HFI funding does not go below the 1.7 million each year, could increase. I'm optimistic it's going to increase. Our HFI presentation last month was amazing. I mean, we had the numbers showing how many individuals we helped, what the costs were for it. So hopefully all that information gets to those, downstate that make the decision and realize the impact that those funds had, especially, in St. Joe County.
And I would like to thank Amy. She is incredible. She keeps us on task. And I know you guys know from seeing her work that she dots the i's and crosses the t's, and I really appreciate that.
All right, thank you.
You're welcome.
Any other questions on the health officer's report? If not, I'll entertain a motion to approve.
I motion to approve the health officer's report.
A motion and a second. Any further discussion? Hearing none, all those in favor, please say aye.
Aye.
Opposed, say nay. Motion carries. Next section of our agenda, new business, item 2630, discussion and vote for some job descriptions for administrative assistant, nursing, environmental health specialist, and environmental health specialist, septic coordinator.
All right, Mike Rubel, Department of Health, Director of Operations. So we have 3 job descriptions in front of you tonight. 2 of them are one is the administrative assistant for nursing. There is a small section to update you with. That update has been given to Jenny. I can read it to you. I also have paper copies if you'd like to see. It is in section 2, describing the difficulty of work. It's roughly a 2 to 3 sentence paragraph. The change has to do with the old paragraph was more geared for a clinical staff person, like a nurse. This position is not clinical, so we wanted to remove those clinical pieces out of it. Not a hugely dramatic change, but it is more appropriate to a non-clinical person. I can read that to you, or if you'd like to have the copy, I can hand these out to you. So
I'm gonna hand them out.
Just read it.
You're gonna hand them.
Oh, I was saying he could read it. It's only a couple sentences, right?
You can hand them out. We'll just take a quick
Okay.
look at them.
How about I'll read it so that it's on the record, and then I can hand them out following. So the difficulty of work section will read, incumbent's work is broad in range and often requires careful consideration of complex circumstances and variables. Incumbent performs duties according to established policies and procedures, exercising judgment to effectively support health programs, communicate with individuals and groups, and to provide information and assistance. So that would be the only change to that job description. The other job description actually was before you within the last year and a half. That would have been the environmental health specialist coordinator septic. This position has been mainly updated. The big change to this is adding that standardized language that we talk about every month. The job duty section is slightly updated. I wouldn't say that it's anything very dramatic from what was previously approved. The last position is the environmental health specialist. If you remember, we came to you in January with an EHS-septic position. At the time, under the old leadership, what we were having was more of EHSs that were split among the various programming. With our new leadership at the director level, what we talked about from there was maybe going back to more of a general EHS description. where the job description that you have in front of you lists all of the programs. The language in the job description reflects that each environmental health specialist will be assigned to one area primarily, but they will be responsible for learning and understanding all the other programs so that they can cross-train and cross-support the programs across, depending on the needs that we have. We have some of our programs have some seasonality where they're busier over other times of the year. We want to be able to support our colleagues, support the public, make sure that the work is being done in a timely fashion. And the feeling was that if we make this a little more general, we still have the opportunity to specialize by program, but then to better support on the back end. And so that is the major change. And that's why you see something that looks similar to what you just saw a few months ago. But in talking with Breezy as the new director, talking with Dr. Migliore, Dr. Purushottam, we felt that this might be a better approach moving forward. And that's why we're asking you to reconsider this. The other piece of that is that it will also take all of those individual EHS positions that were more specialized, and we will condense them into a single job description going forward. And I'm happy to answer questions beyond that.
The only thing I have a question about is some of the stuff in the job description. It talks about designing the systems and all that. I thought that the code that we were going on, that you had to have a soil scientist and a septic specialist design that system. We don't actually design that.
Actually, Breezy, if you don't mind. Thank you.
Hi, Brianna McCall, Director of Environmental Health. So we don't design per se, but we do have recommendations. There are times where we would not provide a design as a submittal. So we would never give someone something we design and have them submit that back to us. But there are instances where we do collaborate with different installers, soil scientists, engineers, whoever, and just kind of collaborate on what we saw, what they saw. So they will be designing, but not in the sense that they would be submitting that for an application.
Okay. So just maybe the language should be more review. Because it says develops minimum specs.
Yes, we do develop specifications. That is part of the application process.
I wasn't thinking that was part of that code we were following.
Yes, no, that is part of the code. So for specifications, whenever somebody submits soil borings, designs, whatever, we have to say, based on what's been provided to us, a sheet that says what the tank size is, what type of system it is, where it's located, all that fun stuff. Then that person takes it to multiple people so they can get bids and figure out who's going to do the work for them. So that's standard, and that's not something relative to our county.
I just thought about this right now. The subunits, do you think there's a need to list it somewhere in the job description what the subunits are? What all the subunits are, or I literally just thought about this now, so I'm still like thinking in my head.
We did list the subunits as they currently exist, and they appear to be at this point stable. So we felt that that was prudent to just list them individually and list what some of the basic duties would be. It wasn't meant to be all encompassing. There's, of course, the devil's in the details. There are each one of those programs have far more than what is in there, but we tried to list the major pieces of work that would be involved so that that was clear from the job description, so that anyone who is applying for the position has a very a reasonable understanding of the level of detail that role will encompass.
And on page 48, there were just, I think it was three points. They would be like the 1, 2, 3, 4, 5, 6, and 7, where I've just found a couple of edits we're using the may language, may perform. And then there are a couple of points where we don't have that may language. We say instead of, for like the 5th point, it says may perform massage establishment inspections, yada, yada. And then the next sentence, issues permits. And I think we want to say may issue. And then like the next one has the same. So it's just a couple of just grammatical edits, which I'd like to, I can pass this down and just show everybody and then maybe show you, but if we can just pass it with a few grammatical edits, I can kind of show you everybody when I'm just that's all I need.
So instead of the will, you're putting may.
Because I think that the idea is that you want to use the may language, if I'm correct, because it's not something that like nobody's necessarily going to do all of this stuff, especially not day to day. You're still going to kind of informally subspecialize, but everybody may be asked to do it. So it's not necessarily what they're, not everybody's necessarily going to be doing well in
Sure.
students, but may need to, correct? Yes.
Yes.
That's it.
Sense.
I can update that.
Oh.
I can go through and update.
Yeah, I've got them written, so I can just show you.
Mhm.
Anybody else is okay, then
I've lost track of what we need to,
okay.
what kind of motion we need here.
So just to recap, hopefully, depending on how you decide, we would accept all of these as a bundle because they've all been reviewed, by each unit, by the health officers, by the director of operations and legal. Do you want to state the changes that we're making?
Not really, but
The
we
grammatical
have
one?
to.
Well, maybe,
Marcel, any?
do you want to make a motion and then?
I will make a motion to approve all of the 3 job descriptions together with the changes saying may instead of will in the environmental health unit description.
Page 48.
Page 48.
We have a motion. Do we have a second?
I'll second.
Any further discussion or further clarification or question? Hearing none, all those in favor, please say aye.
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 Opposed, say nay. Motion carries. Thank you. Next item on the agenda, 2631, discussion and vote fee schedule for the new nursing unit only.
Yes, the fees from VaxCare as well as Sanofi, who we get the vaccines from that we purchase from, have significantly increased in price. So the changes are shown on that fee schedule there. We would like approval to be able to have that go to the county council. And we have asked for a suspension of rules at their next meeting to be able to have a first reading, a committee meeting, and a public hearing so we can get these prices in effect as soon as possible and get those patients back in for their vaccinations.
I would just like to say that some of the vaccines have gone up as much as $29 per dose. And now is the busy time, yellow fever I'm thinking of, but the busy time for yellow fever vaccines is now because people are going to be traveling. Now that the weather's getting warmer, students are leaving maybe for a summer internship, that sort of thing. This is not to make money. We do not try to make money off of vaccines. We cover our costs. That's all we want to do. And we found that the reason why we seem sort of urgent with this is we don't want to lose money on vaccinations. And this came the last week of March, I think March 30th or 31st. It was the end of the quarter. Hey, by the way, all your price, we got the notice and everybody had their hair on fire trying to figure out how we're going to not hemorrhage a bunch of red ink. And so part of that involved asking the council to suspend the rules so that we do have some vaccines in storage, but not enough to cover us for a couple of months waiting for somebody to approve just so that we're not eating the cost.
And it is correct that two of these do appear to be less on the new, okay. Which
Correct. If the-
Obviously
if the
goes to
prices-
speaking of the fact that we're not making money,
Correct. If
but
prices go down, we
just making
definitely
sure.
pass that
I
on
thought
to
that
the
was probably
customer.
accurate, but okay. Thank you.
Pages 70 through 73.
71.
Yeah,
Well,
yeah, 70, 71.
no, that was the stuff we can't.
At least that's what's numbered on that. Where it's just oh, is it different? Oh.
Oh,
I got a
yours is
later
different.
version.
Yeah, you have a later version, so the pages are not reliable. Fee schedule number.
The nursing unit.
Yeah,
fee
just for
schedule.
back.
We're talking about the same thing, just different page numbers.
The one, there was one before it that was all of the fees for all the units, but we're not.
Correct.
Correct. We're
touching
not
that
dealing
this
with that at all.
meeting. It's so
Correct.
it's
Just the
just,
Just nursing unit.
okay.
Yeah, just specific to the nursing unit, not anything outside of the one that's just the nursing unit.
Any other questions? If not, I'll entertain a motion.
I move to approve the fee schedule as described for the nursing unit.
Second.
Motion and a second. Any further discussion or questions? Hearing none, all those in favor, please say aye.
Aye.
Opposed, say nay. The motion carries as well. Next section on the agenda, grant request, item 2632, discussion and vote to receive Delta Dental Foundation donations, I believe.
A bit of a tongue twister. Ashley Hellman again, Director of Nursing. I'm here on behalf of our amazing school liaison who continues to find resources and ways that we can support our school community. She has found the Delta Dental Foundation, which is a nonprofit organization, and they will provide adult-sized toothbrushes, toothpaste, and floss monthly. We can request it as needed. It's a big get because we have had the opportunity to have child-sized toothbrushes from the American Dental Association annually, but we have never had a resource for full-size toothbrushes. So we are just asking for the approval to request these items monthly as needed.
Just so this will be a recurring, so the approval will be for a recurring monthly request of the amounts that you have here, 100 coloring books, 240 toothbrushes, 200 travel size toothpaste, and 100 dental floss.
That is the maximum that we can request every month. So yes, and I forgot the coloring books, but
Okay.
also those as well. Yes. So we may not request the maximum amount some months. It just depends on what's going on and what the needs are, what we're being asked for, but it would be no more than that.
I guess my only question is that on this request, it doesn't say a monthly recurring donation. Should we note that just so that everybody's aware that that's what we've approved? Okay,
Yes.
all right, so
Makes sense.
I think we'll have to change the
Like-
letter that Dr. Migliore will have to edit. The Department of Health would like your support to receive donations,
Monthly.
a monthly recurring donation.
You could just put monthly at the end of it. Include monthly colon in the list.
I think maybe saying monthly
Think-
recurring.
You could just make a motion to make, to have Dr. Migalori make her letter monthly reoccurring and
Okay.
leave it to
All right.
her professional.
Okay,
If
All
you make a motion to accept it with this following amendment,
okay.
then somebody can
All
second
right,
it.
that sounds much easier. Okay, I move to accept, approve, not accept, approve
And you're,
Approve.
mm,
the request for this donation with the amendment that Dr. Migliore, using her discretion, editorial discretion, include that it is a monthly recurring donation of up to the number of items, number and description of items listed on the current letter.
Second.
Beautiful. All right. We have a motion and a second. Any further discussion? Hearing none, all those in favor, please say aye.
Aye.
Opposed, say nay. Motion carries. Old business, so we're on to public comment, yes. We have nobody on the list, okay? Then, thank you all. For our next meeting will be, sorry,
May 20th?
I'm having trouble finding my.
May 20th.
You take it.
I did. I totally took it.
Our next meeting will be May 20th, right here in this room at 4:30. Thank you all for attending. We are adjourned.
Thank you.
Thank you.
Oh, I will not be able to be at the June meeting. But I will be at the meeting.
Okay.